Welcome to the debate. Today, we're diving into a really crucial comparison of modern thyroidectomy techniques. We're drawing insights from an intelligent review by Dr. Reza Lankarni, who's a distinguished general surgeon, the founder of the Surgical Pioneering newsletter and podcast series, and also an editorial board member of the Genesis Journal of Surgery and Medicine.
That's right. And our conversation today is going to unpack two prominent approaches: the transoral endoscopic thyroidectomy vestibular approach, that's TOTVA, and the minimally invasive non-endoscopic thyroidectomy, or MINET.
And the central question really that we're wrestling with is this. Is TOTVA, which gets a lot of attention for its scarless outcome, is it truly a superior alternative to MINET when you consider the whole picture? Surgical safety, patient experience, cost, and maybe most critically, the integrity of the pathological specimen.
Exactly. So I'll be making the case for TOEDVA as a significant advancement in the field.
And I'll be focusing on, let's say, the substantive trade-offs and the practical challenges that come with adopting it.
Okay, so for me, TOEDVA isn't just like an incremental step. It truly represents a transformative leap forward in thyroid surgery, and it's driven by one profoundly compelling advantage: the complete absence of a visible neck scar. I mean, just imagine the impact of that for a patient. It's really a game changer for quality of life, for self-perception, especially with surgery on such a visible part of the body. Figure 2 in the review illustrates this vividly, showing a postoperative neck that looks, virtually untouched.
Mm-hmm.
But TOEDVA's benefits, they go well beyond just the aesthetics. The data points to a remarkably strong safety profile. When we look at overall complication rates, TOEDVA actually performs comparably to MINET, which shows that this, advanced technique doesn't seem to compromise general patient safety. Where TOEDVA really distinguishes itself, though, is in its superior outcomes for preserving critical anatomical and physiological structures. The dramatic reduction in intraoperative neuromonitoring, or IO&M alerts, for signal reduction greater than 50%, it's just 1.6% in TOEDVA compared to 5.0% in MINET. That isn't just a number. It points to a fundamentally gentler, more precise manipulation of these delicate structures under endoscopic view.
Right.
And even more striking is the significantly lower traction-related I&M alert rate. It drops to a remarkable 0.4% from 3.4% in MINET. Now, this suggests a potentially refined surgical philosophy where we can actively minimize the very stresses that contribute to nerve injury. And the impact on parathyroid gland preservation, it's equally compelling. A significantly lower incidence of inadvertently resected parathyroid glands in TOEDVA, 4.7% versus 10.9% from MINET. This is, I think, a direct benefit of the enhanced, magnified visualization you get with the endoscopic approach, leading to better long-term patient well-being by reducing the risks of, vocal cord palsy and hypoparathyroidism.
Okay. I understand the compelling vision you've laid out. And look, the cosmetic appeal of TOEDVA is indeed powerful. It speaks to a very real patient concern, no doubt. However, I believe we must shift our focus to the substantial practical, clinical, and frankly, systemic trade-offs that the study's data clearly highlight. These aren't minor issues. These are fundamental considerations for any new surgical approach. Let's just start with the operating room. The review reveals a significantly longer operative duration for TOEDVA, averaging nearly 128 minutes. That's almost double the 68 minutes for MINET.
Mm-hmm.
And that's before we even count the longer preparation time, which is also noted. This isn't just a matter of waiting a bit longer in the OR. This extended time places, immense demands on operating room schedules, on personnel, on institutional resources. It impacts hospital throughput and the availability of surgical slots for other patients. Then there's the financial reality. The overall costs associated with TOTVA are considerably higher. A mean of $4,680 compared to $2,734 for MINET. That's a difference of nearly $2,000 per procedure. This isn't a small premium. It's a significant financial burden that health systems and potentially patients have to absorb.
Okay, but
my deepest concern, and honestly one that resonates profoundly within pathology labs, lies squarely in the area of specimen integrity. Table 3 in the review, it paints a stark picture here. a significantly higher rate of specimen disruption in TUEFA, where the tissue sample provided for diagnosis becomes fragmented, making accurate evaluation much harder. We're talking 12.9% versus just 3.8% from MyNet. There's also a higher rate of incomplete tumor capsule integrity noted in TUEFA. Now think about the ripple effect of that. How does it impact a pathologist's ability to truly differentiate, say, a benign lesion from an early malignancy when the architectural details are compromised? This can severely complicate diagnosis, leading to uncertainty and potentially altering critical patient management decisions. Furthermore, and perhaps counterintuitively for a, quote, minimally invasive procedure, TOE-TVA patients experience significantly higher post-operative visual analog scale, or VAS, pain scores compared to MyNet patients. Now, this finding, while maybe not a deal breaker on its own, it adds another layer of complexity to the whole patient experience argument.
I appreciate the practical concerns you've raised, and yes, hospital throughput and financial implications are indeed critical considerations in modern healthcare. But I think we need to frame this discussion about cost and time differently. Dismissing the profound psychological impact of a scarless outcome for patients, particularly in such a visible area, I think that overlooks a crucial component of patient-centered care. For many people, this isn't merely a cosmetic preference. It's a significant quality of life improvement that deeply affects their self-esteem, how they reintegrate into their lives post-surgery.
Sure, I get that.
And while I acknowledge the longer operative times and the higher current costs associated with TUEFA, this is often characteristic of any pioneering, technologically advanced surgical technique. These are not static numbers. These challenges are manageable and, importantly, are highly likely to decrease with increased surgeon experience, optimized workflows, and ongoing technological advancements, much as we've seen operative times per minute itself improve over time, as the authors note.
We could frame the additional time and cost not as a burden, but as an investment in genuinely patient-centered care, prioritizing both functional and profound aesthetic outcomes. The value proposition here, I think, extends far beyond simple monetary cost to encompass the patient's holistic well-being and long-term satisfaction. That's a compelling vision, I'll grant you. But I have to challenge the practicality of categorizing these significant increases in operative time and cost as simply an investment that will somehow magically resolve itself. An hour longer in the operating room, almost doubling the operative time, that isn't a minor hiccup that just fades with a little experience. It profoundly impacts hospital throughput. It leads to reduced capacity for other vital surgeries, increases wait times for patients, and places an additional very tangible strain on staff and resources. This isn't just about direct financial costs. There are immense, intangible, institutional costs tied to delayed OR turnover and stretched personnel. We're talking about almost 2,000 more per procedure. In any healthcare system, whether it's publicly funded or private, these are not small figures that can be dismissed as, temporary inconveniences.
These are significant systemic burdens that need to be seriously weighed against what is, at its core, a patient preference for scar avoidance, especially when we consider foundational aspects like surgical efficacy, resource allocation, and equitable access to care. We need to be realistic about these trade-offs and their broad implications.
I understand the practical implications you're highlighting, of course, but let's refocus on surgical safety for a moment, because TOVEA truly seems to excel in preserving critical structures, which are foundational to patient well-being regardless of cost or operative time. I want to reiterate the superior nerve and parathyroid preservation rates we see in TOVA. The study clearly shows lower IONM alerts, only 1.6% for TOVEA, compared to 5.0% for MyNet, and particularly for traction-related alerts, which dropped from 3.4% in MyNet to a remarkable 0.4% in TOVEA. That's a profound difference. It indicates a tangible reduction in neural stress during the procedure.
Okay.
And the fewer inadvertently resected parathyroid bands, 4.7% versus 10.9% in MyNet, that is a direct, clinically impactful benefit. Think about the long-term consequences. Nerve injury can lead to vocal cord palsy, profoundly impacting a patient's voice, their ability to communicate, their overall quality of life. Parathyroid injury can lead to lifelong hypoparathyroidism, requiring ongoing medication and monitoring for calcium imbalances. IONOM, in this context, serves as an invaluable early warning system, allowing surgeons to detect and potentially correct nerve compromise before permanent damage occurs. This enhanced visualization with endoscopic techniques, it directly translates to superior anatomical precision, reducing complications that have significant lasting impacts on patient function. We're talking about avoiding serious permanent functional impairments here.
I agree that prioritizing nerve and parathyroid preservation is paramount, and your points on those rates are indeed noteworthy. However, are we truly weighing one aspect of surgical safety against another when we consider the critical implications of compromised specimen integrity? While the nerve and parathyroid data are positive, they simply cannot overshadow the foundational challenge that a high rate of specimen disruption presents. Table 3 is quite stark here. Specimen disruption was much more common in TOE-TVA at 12.9% versus a much lower 3.8% in MINUTE. Incomplete tumor capsule integrity was also higher in TOE-TVA. Now, for a pathologist, a disrupted or fragmented specimen can profoundly obscure key diagnostic features. Think about the critical nuances when trying to distinguish between, say, a benign follicular adenoma and a malignant follicular carcinoma. The architectural integrity of the capsule is absolutely vital. This isn't a minor detail, it's fundamental to making an accurate diagnosis, especially for those incidental malignancies that weren't suspected preoperatively. Fragmentation can create a false impression of extrathyroidal extension or raise unwarranted suspicion, potentially altering clinical management. The American Joint Committee on Cancer's 8th edition guidelines themselves highlight how fragmented specimens hinder accurate evaluation and staging. Imagine the diagnostic uncertainty this creates, the potential need for further invasive procedures, or just a difficulty in making informed decisions regarding adjuvant treatment or surveillance. Accurate and unequivocal diagnosis is paramount to effective cancer treatment, and TTO-EVA, as currently performed based on this data, presents a significant and, I think, concerning risk in this regard. This impacts patients' trust, clinician decision-making, and potentially long-term outcomes in a way that is incredibly difficult to quantify.
I see why you emphasize that, and I understand the gravity of diagnostic certainty. It's absolutely essential. However, regarding the higher postoperative VAS pain scores for TOE-TV, while this study does show a mean of 0.88 for TOE-TV compared to 0.38 for MINUTE, it's vital, I think, to place this within a broader clinical context. Prior large-scale studies, like the work by Anawang and colleagues back in 2018 involving thousands of patients, they consistently reported lower mean VAS pain scores for TOE-TV compared to conventional open thyroidectomy.
Right, compared to open, yes.
Exactly. So this suggests that while TOE-TVA might result in slightly more acute pain than MINUTE, in the immediate postoperative period, it still represents a significant improvement over the traditional methods, which, let's face it, many patients are still facing. Furthermore, pain management protocols in modern surgery are highly standardized and incredibly effective. With appropriate patient counseling, we can set realistic expectations for discomfort and leverage multimodal analgesic approaches to ensure patient comfort remains well within acceptable, manageable clinical parameters. The patient experience, while perhaps not quite as sensation-free as MINUTE initially, is still largely positive, especially when you weigh it against the profound and lasting cosmetic benefits of avoiding that neck scar.
I'm sorry, but I just don't quite buy that line of reasoning. We need to critically evaluate this study's findings, which provide a robust matched comparison specifically between TOEVA and MINUTE. The finding of higher pain for TOEVA with a mean of 0.88 compared to 0.38 for MINUTE is a direct, statistically significant result from a rigorously controlled comparison. It shouldn't be dismissed or diluted by referencing comparisons to older, more invasive conventional methods when we are directly comparing two minimally invasive approaches. This is about comparing apples to apples, right? And this study clearly shows a disadvantage for TOEVA on immediate pain scores. Furthermore, we must critically address one of the study's significant limitations, the patient BMI. The study population had a relatively lower BMI. This is a critical factor limiting the generalization of these findings. Patients with higher BMIs often present greater surgical complexity. Just think about the anatomical challenges of navigating the oral vestibule and neck planes through an endoscopic transoral approach when there's more adipose tissue. Such patients could potentially experience even greater technical difficulty, longer operative times, and perhaps exacerbated discomfort or pain with TOV-TVA. This raises significant questions about how widely these positive outcomes for TOV-TVA, particularly regarding that nerve preservation, can truly be applied across the broader patient population we actually encounter in practice.
Okay, to summarize, I firmly believe TOTVA represents an important stride, a truly progressive step in thyroid surgery. It offers clear and compelling advantages in providing scarless cosmetic outcomes, which, as we discussed, is a profound driver of patient satisfaction and psychological well-being. Moreover, it demonstrates superior preservation of critical structures like the recurrent laryngeal nerves and parathyroid glands. These have tangible and lasting long-term health benefits, avoiding significant functional impairments. While acknowledging the current challenges in operative duration and cost, I maintain these are areas ripe for continued refinement and improvement. As surgeons gain more experience, refine their techniques, and as technology advances, these metrics are highly likely to improve significantly. This makes TOTVA an increasingly valuable and accessible option for carefully selected patients who prioritize both optimal functional and aesthetic results. It really pushes the boundaries of what's possible for patient care.
And my position remains that while the vision of scarless surgery is indeed appealing, and the advantages in nerve preservation are certainly noteworthy, the current evidence, particularly regarding significantly increased operative time, considerably higher costs, and those critical concerns about pathological specimen integrity, demands a cautious and highly selective approach to TOTVA. These are not minor inconveniences. These substantive trade-offs impose significant demands on healthcare resources and, perhaps more importantly, introduce potential diagnostic uncertainties that directly impact patient management and can have profound downstream effects. These challenges must be thoroughly understood and meticulously discussed with patients, alongside clear counseling on the higher pain scores and the current limitations regarding generalizability, before considering TOTVA as the preferred option.
In this discussion truly illuminates the complex interplay of factors involved in adopting new surgical innovations. It underscores the ongoing need for careful patient selection and, frankly, further prospective evaluation to fully understand the long-term implications and the true value proposition of these techniques.
Indeed, it's clear there's much more to explore in this material to ensure we are always making the best, most informed decisions for our patients, balancing innovation with established clinical priorities.
This discussion was based on an intellectual review by Dr. Reza Lankarani, editorial board member of the Genesis Journal of Surgery and Medicine. To access additional details, please refer to the Surgical Pioneering podcast series application, which is available at the following link: https://surgicalpioneer.codex.me.